Welcome to the SS White Dental Core Insights podcast. Here's your host, CEO Tom Gallop.
Welcome. This is Tom Gallop. I'm the CEO and owner of SS White, and I'm real pleased to have Dr. Howard Glazer with us today, talking about core insights. What were the dental hacks that caused him to create a radically successful practice, as well as be an amazing key opinion leader and educator in our marketplace. So I've known Howard, I hate to say it, over 30 years, but God, it's been a great experience for me personally. I've always known him to be someone that's knowledgeable, but yet would help me understand it. Not speak over me, but also help me get there. But he's approachable. He cares, and he's a dedicated key opinion leader who also practices. A lot of our key opinion leaders today just focus on developing product or being a spokesperson for companies. And I've always admired how Howard still maintains a great practice in New Jersey. I'm very excited to have him, appreciate him joining me. He's got a boatload of background data, experiences, past, present, the AGD, associate clinical professor at Albert Einstein, a fellow at the American College of Dentists, International College of Dentists, American Society of Dental Aesthetics, and I think really cool, he's a forensic dental consultant working in New York City, leading clinician according to a lot of pubs, and he's published for over 15 years a couple different articles that have really been, I think, helpful in the marketplace. Latest is I Have It, You Need It in Dental Economics. So welcome, Dr. Howard Glazer. Thanks for joining
Tom,
the show.
thank you. It's been a great ride together so far, and it's a mutual admiration for sure. And I applaud your mind, and I applaud what you're trying to do. And SS White, in my mind, has always taken the lead on a lot of different projects and a lot of different directions. So from back when SS White started out 175 years ago,
yeah,
that's long haul. You guys are in it to win it, and you're winning it.
Oh, we've definitely appreciated the collaboration and feedback from great doctors like you to help us steer us on how to conserve healthy tissue, or how to create better patient outcomes, or save time, or what works or doesn't work in your hands. And I think your insights have been really helpful in a lot of key products for us. So we really appreciate your inputs and those of other doctors as well.
Very good. Well, I thank you. You fit the criteria that when I look for new products to evaluate, I use a very simple criteria. I'm not Gordy Christensen. I have a fancy lab in Provo. You see part of my small office here in Fort Lee, New Jersey. So I look for things that are faster. I look for things that are easier. I look for things that are better for me, the doctor, but they have to be better for the consumer, for the patient, because they are the ultimate end user. And of course, reasonably priced. You guys have always met that criteria. And they're worthwhile products. And maybe during the time we'll talk about some of my favorites, but
Sure.
Let's jump in. What's on your mind, Tom?
Well, I think we're going to be talking to doctors that are just getting out of school, or doctors that have been practicing for 5 or 10 years and are still maybe having to experience some of the struggles or challenges you've overcome, or that you've got some insight on. So I like to look at, imagining back the 27-year-old Howard Glazer. What would you tell yourself, about dentistry now? And what were some of your concerns and fears back when you were just getting in the biz? And how do you think about it now?
Well, 27 years ago, first thing I would have said, go get a haircut, because I had hair back then. But I was very blessed. I had a wonderful mentor in dentistry, and it was my father.
Wow.
He was a practicing dentist since 1947, and he retired at age 65, and I took over the practice at that point. But he was an incredible, he was one of the first four-hand dentists, one of the first guys to practice sit-down dentistry. Had an Alabama cart when it first came out. He was way ahead of the curve. And I think I learned a tremendous amount at his hands, and not as his feet, but at his hands, in learning everything from technique to how to talk to a patient. And the bottom line with my dad was always, treat them as you would like to be treated. And I've never forgotten that. And that's a benchmark phrase in in anything you should do. You know, I have a picture in my mind when I used to ride the subways in New York, and there was a picture of a hot dog with a little flag in it with a guy who signed his name on the flag, and it said, "Do everything you do as if you had to sign your name to it."
Mm.
And that's a very good way to practice. And so that somebody out there is 27 years old, first of all, let me congratulate them on choosing the right profession. I honestly believe it's the wrong time to go into medicine for lots of reasons. I think organized, and I shouldn't say that, I think managed care has mangled care and has destroyed medicine as we knew it back. I'm older than you for sure, but has destroyed the concept of medicine. Thankfully, in dentistry, we've not seen that happen to the same degree, although I got to tell you, I think DSOs are doing a lot of that potentially, as well as PPOs and things like that. But the chance for excellent dentistry occurs no matter what type of practice you have. So I advocate excellence in dentistry, and I practice excellence in dentistry. I've been in practice 45 years. I'm treating third generation patients, some fourth generation patients. That's how old I've gotten. But it's been a great ride, and I truly believe this is a fabulous profession. I mean, and companies like yourself, which you come out with, Fisherotomy, you know, Jazz Polishers, you know, you're coming out with stuff that helps me help my patients. Bottom line, what can I do to help my patients? And
Okay, so
altruistic.
you get
Go
out of
ahead.
dental school, you come work for your dad. Could you walk us through the kind of some of the major milestones in your practice? Like, this is when I learned, you know, this was a major moment for me in terms of learning a new procedure, or maybe how to grow
Great.
the practice, or, I mean, what were some of the keys? I mean, you saw how to treat a patient from your doctor or from your dad, but what were some of the keys in terms of adding your clinical knowledge and your procedural knowledge? How is a young doctor going to navigate, you know, which CE courses to take and which doctors to work with, and who are some of your favorites?
Wow, that's about 7 hours worth of information in one
Yeah.
question. Let me start by saying I break it down initially 3 ways. Number one, I think that dental school teaches you the vocabulary. And after I got out of dental school, I knew all the right language. And then I did a 1-year GPR program, which I always advocate.
Mm-hmm.
And that GPR allowed me to take that vocabulary and speak in sentences. And then when I got out of my residency, I went into private practice, and all of a sudden I was able to have conversations. And so what my father did when I went into practice, I started moonlighting while I was a resident. And when I got out of practice, you know, after 6 months of moonlighting, I said, Dad, you know, he was worried I was taking money, would potentially take money out of his pocket in order to feed me patients. Not that he wouldn't have as a father. He was a great father aside from a great dental mentor. But I showed him within 6 months that wasn't the case.
Right.
Couple of things happened. Number one, the demographics of the practice that this young dentist will go into will immediately drop to the young dentist's age, because patients of the practice will see a continuity of care. So they bring the age factor that shows patients that there's a future in that particular practice where they are. Number one. Number two, they've got to stay current. If dental school just gave you the vocabulary, you need to continue the conversation with what I believe is lifelong learning. And that's why I look to the Academy of General Dentistry right away. And not only because of their educational prowess, if you will, and that they foster the belief in continuing education lifetime, but the fact that I also worked myself up in organized dentistry, because I'm a guy that if you're going to pay dues, I want to have a say in what's going on. So I like to be a player along with a participant, as well as, and I like to lead if I can, which drives my wife crazy because she likes to lead when we dance, but that's another story. So that's a benchmark.
So to me, you've talked about a couple beliefs that you've got. One is obviously treat them the way you want to be treated. Another is lifelong learner. Those are two beliefs that have really driven great behavior and results for you. What do you think
Absolutely.
what are some of the beliefs that you think younger doctors maybe in some of your audiences don't yet have that they could benefit by reconsidering? Or, I mean, being a lifelong learner, if we could wave a magic wand, it would transform our industry. I love it.
Yeah.
Treating the patient the way we want to be treated. If we could just do those two things, we'd be in really good shape.
In life
But
in general. Yeah.
what about, is there any other limiting beliefs that you see the average dentist has that comes back and bites them eventually, or some of the younger doctors may have to work through eventually?
The answer is yes, and I think it's an economic one, and it's a sign of the times. Unfortunately, too many of our younger practitioners are coming out with a huge amount of debt.
Yeah.
With a huge amount of debt, and they've got lifelong ambitions like you and I had, to have a family, to have a house, to own a practice, to raise children. All of it takes money, and they've got this huge debt load. So where my fear comes is that they look to the money first. In other words, the debt's going to drive them into a situation.
Right. What's my cost per hour to do this treatment? Should I do it, or should I send it to the specialist, or should I even learn about it? I should learn about implants, and this is why. And when I learn about implants, I better diagnose implants.
Well, let's stop right there. If I had to advise a young 27-year-old coming out of school and getting into practice today, two things I think you need to learn right in the beginning that are assets to any practice, whether it's your own that you'll own or whether you're coming to work for me as an associate. You need to know clear aligner therapy, okay? And you need to know how to surgically place implants.
Let's start with the first one. Go a little bit more detail. What do you mean by clear aligner therapy?
Well, clear aligner therapy, nobody to this day really wants what I grew up with, railroad tracks for braces. Of course, now we have clear plastic braces. It doesn't look metal, but everybody wants the quote Invisalign type treatment. That's why you've got probably a half a dozen to a dozen companies in the marketplace right now, either professionally, meaning in the office, or over the counter, that you can buy a boil and bite impression and send it out for a set of trays. That's what people want. They want instant gratification. They want it easier. They want it for less money. And, devil be damned. So the treatment doesn't come out right in the posterior. They're just looking at the 6 anteriors. That's wrong. So I want somebody who's knowledgeable as a dental professional to guide them.
So how much time do you think it takes, and what kind of course level work would you think it takes to get to a competent to excelling in that area?
Well, competency comes with clinical experience. Knowledge comes with taking the right courses, whether it's an Invisalign practitioner course, whether it's a Clear Correct course. Get a solid, established company course under your belt. Doesn't mean that you have to use their product. It's going to give you the foundations and the nuances of that product. Then you can become a better judge of what other clear aligners might do the same treatment. We've heard of 6-month smiles. And but the bottom line here, Tom, is being able to evaluate the case and make sure that the choice you make in clear aligners is correct for the patient's needs, or do they have to have traditional orthodontic treatment? And not clear aligner therapy is not for everybody. It's not the panacea. Right. But they need to educate themselves, and they need to work with a company that will handhold them in the beginning. And I mean that in the kindest way, because it's difficult. You want to be able to see positive clinical results.
So, so your orthodontist, your endodontist, your oral surgeon, I'm sure you've had experiences where it's been exceptional and you've had a great partnership, and I'm sure, unfortunately, maybe you've had some people they've had to stop working with. Can you speak about how you go about finding a great specialist to partner with in your practice, whether it's your endodontist, your oral surgeon, your perio, your lab?
So I think these are great questions, Tom. You're going off the script, but this is great questions. Great questions. So what I did, before I was practicing here in New Jersey, I practiced in the Bronx, New York, and I had 2 practices for a while. So I literally got lucky. The oral surgeon on my floor in the building who was here at that time, he's no longer here, was a great oral surgeon, had a good reputation. I researched it by asking other colleagues I knew in New Jersey who they're referring to. And then I called them. I went out to lunch, had a conversation. We shared some of the same belief structure, the same way we would treat patients. And I think that's it. Now, once I had a good oral surgeon on my team, if you will, I asked them, who do you see as a good endodontist in town? And so on and so forth. Then I asked the endodontist and the surgeon, who do they see as a good periodontist? And so I built the tree from that. And I got lucky by finding the right person. But if you didn't have that opportunity,
I think people travel in herds together. Like the guys that are really minimally invasive and really care about it, they know the minimally invasive endodontist, or they know they know the profiteer guy. If they're the profiteer guy, I don't mean to say it that way, but
no, but it's true. It's true.
When I move into a new area, and I haven't moved that often, but I call dental labs and ask who's honest, who cares if they cut a prep who would want you to send it back to them if it didn't fit well, and who would want you to make it fit. And when I came to Colorado, I called 2 labs and I asked for 3 doctors that were honest, paid their bills, and wanted to do great work. And I got the same doctor name from both labs, and I've had great experience working with that doctor. So I love the idea of asking other specialists to name, to understand their belief system about what they want to do, what's acceptable, what's not acceptable for them, seeing if you have alignment on your beliefs and your values, and then using them as a great alternative to meeting other specialists, because they get it. And I think it's a great suggestion.
I mean, I have no problem when I go on vacation or if I'm out lecturing, and if number one, I generally leave my cell phone number when I'm out, because I'm the captain of the ship. I want to know, these are my patients. We've grown old together, if you will, and new patients were growing old together. But I will then call the specialist. Now, I have typically if they can't reach me, I have an endodontist and an oral surgeon whom I work with who share the same practice beliefs.
Mm-hmm.
They're conservative. They want to save teeth. So I've heard horror stories where if you leave the oral surgeon on call, they're always going to get the tooth taken out. And if you leave the endodontist on call, they're always going to get root canal. Well, these guys know how to re-cement a crown. They know how to put a temporary filling in. And they know that I refer to, we work as a triangle.
If you were a young doctor and you had a conflict with an endodontist or an oral surgeon on that topic, how would you discuss it with them? What would you do?
You know me, Tom, I'd call them out. I'd lay it out. And believe it or not, I had that kind of a situation come up with a patient. And then I said, listen, I'm lending you my patient. You're an extension of me. You're an extension of my office. I wasn't happy with the way I heard you talk to the patient and how you said things. So I tell you, I've got a lot of difficulty referring future cases to you.
Yeah, I think it makes sense to have the confrontational in a carefrontational, however you want to state it, conversation to let them know you're doing them a service. By the way, you're telling them why you're no longer going to use them, or what they got to do to earn back your business. But I personally think that we should be. I think the endodontist, for example, really understands how to do a root canal at amazing levels. They got their cone beam. They've got their ability to really get in and navigate curvy canals and do retreatments. They're an essential part of our business. And they don't have to live with the crown on top of the tooth for the next 2, 3, 5, 20 years.
I do.
So I think it's got to be a collaborative effort, and they got to be able to take coaching from a GP. If you're not giving me enough tooth structure to work with, or somehow I'm going to have a weakened foundation and this thing's going to fracture and last 2 years and the patient's going to have to go to an implant right away, you got to be able to have that conversation with the endodontist to say, you got to be better.
No, 100%. And that's why even when number one, when I've had these I love the term carefrontational. I always preface it that what I'm about to talk to you about really has nothing to do with your clinical skill, because I think their clinical skill is good. And who am I to judge? You wouldn't
have been with them in the first place.
Correct.
Right?
If I didn't believe in it, I wouldn't have. It was really always, it came down to how they handled the patient.
Oh, so
and
it's
what
more,
the outcome was.
it wasn't normally in a clinical setting that you had to call them out. It was normally on how they did their scheduling or how they talked to my patients or.
More so for that. There's been one or two instances where, frankly, it was a periodontist who placed an implant at an improper angle and then had the audacity to say to me, well, you know, they have angulated abutments. You can overcompensate this, when this was at 45 degrees into the hard palate. So, I mean, so I basically said to him, I said, here's what you're going to do. You're going to recall the patient.
Yeah.
You're going to remove the implant. You're going to replace a graft. You're going to restore the implant if the patient would allow you to do that. And then you're going to do this all, and you're not going to charge them a red cent because you screwed up.
What do you say?
He said, I hear you. And he did it. And he never
I
get
think we
another
should give
patient
them a
from me.
chance. I think we should give people a chance to be
A
great.
chance is fair,
Yeah.
Tom. A chance
Yeah.
to reclaim is good.
We all screw up. We got to give people the specialists that work with us or our staff a chance to really do great work. But I think we have to define what great looks like. And sometimes that's what it takes for people to see this is what great looks like.
You know, I introduced my endodontist to some of your endodontic instruments because they allow for conservative endodontic access. Okay, and that's key because you hit the nail on the head. The biggest problem I've seen with endodontic return of patient to me for that post and core is when they've left me 1.5 millimeter walls on a bicuspid.
We call it the Schilder prep, right? Where they just blow out the tooth.
It might as well. And then they go and they have a sandwich and they snap the tooth off at the neck, and my oral surgeon gets a call, you know?
Yeah, well, and the endodontist doesn't, a lot of times they even get feedback that case failed. They don't even know. So, I mean, we have to tell the endodontist this case failed. The research is really amazing out there now. If we can conserve 40 to 70% more pericervical dentin, we can increase the force resistance leading to fractures by 5x.
Amen. Amen. That's long-term probability for a tooth. You're giving patients success. You know, I've heard horrible people that have said, you know, the only way to do a good endodontic treatment is to remove the tooth and put an implant in. I mean, that's horseshit. That's horseshit.
Yeah.
You know, you hit the nail on the head when you said that conversation. You've got to have a conversation. You've got to have like outcome beliefs, and don't fear talking to your endodontist. I want the GP always thinks that they're here and the specialist is here, and that's been a false belief forever. You know, if anybody, I'm here, they're here to help me and my patients. Okay, so I want a team approach. You need to be able to converse.
I think that's another belief that we really could benefit in the market by understanding, and that's to really have great collaborative effort between GP specialists and manufacturer. Frankly, we got to be all at the table talking, and it's not about ego. It's about what are we doing to create better patient outcomes? What are we doing to save time? What are we doing to build the practice? What are we doing to reduce the stress and make it easier to do this and more predictable? And what are the problems that we got to grapple with? And to me, when ego gets in the way, I mean, it's predictable, but it's sad.
Well, you know, so here's a way to break some of that wall down, Tom, that maybe we can give some of the younger guys something that I did way back when. I would take cases where the endodontist has treated the tooth beautifully, and I would take some photographs of the post and the core and how I did it, and I take photographs of the final result with the crown on, and I do it the same way for the implants. And then I would call the specialist's office and I'd say, I'd like to come in and bring lunch and have you and your staff sit down with me and let me show you how I finished the case.
And you made history being the first GP to buy a specialist lunch, by the way.
I've made history several times with that, but you know, and I've done that because the gal at the front desk at the oral surgeon's office or the endodontist's office doesn't know what I do and doesn't know how well I do it. And now I have a chance to show them.
And the endodontist doesn't have a complete idea either. I mean, we're giving them a lot of credit to say they completely know what you do or completely understand when it fails, because you don't always get the feedback. So yeah,
Right.
I think that's an awesome idea.
Yeah, and that's an easy thing to do. And you know what? I end up getting patients from them
Well,
because the GP is not the sole entryway into dental delivery anymore.
well, I also think there's an opportunity for it to go the other way, for the endodontist to show you, hey, here's what you may want to, not maybe you, but the younger doctor, here's what you may want to think when you're doing your anterior access and how you can do it more minimally invasive with less burr run out, or how you can, take care of your bicuspids and not worry about file separation. So I think it could be a good dialogue both ways to really forming that relationship with the endodontist on, hey, we're peers. Here's what I need from you. And then I'm going to give you a lot of business, but you can also help me and train me to be a better endodontist on the cases that I'm going to do. Anterior
Correct.
eyes, or some of the limited cases, or even talk case selection with them or with the oral surgeon as well. And really have an agreement on what are we going to do for oral surgery, or when are we going to go to implants? When are we going to go to endo? When am I going to do it? When can the endodontist do it? And I think having those open conversations, I think, will lead to a lot better partnership and a lot better learning on both sides.
Now, I think that's brilliant, and that's exactly right. I said it before, that there's a triangle, right? And the most common triangle has the patient in the middle. So it's the GP on one side and one or two specialists on either side of that triangle. And everybody's got to be focused on that patient on the inside and what's going to be the best way to get the best outcome for that patient. But it all starts with conversation.
So, all right. So just closing out the specialist thing. So one, we want to be in conversation, even by lunch, shock them, buy the specialist lunch, sit down with their staff, show them a completed case, talk about your challenges and what you need from them, and what you love you get from them, and what sometimes is challenging. And also maybe even ask to set up a time when you can learn from them how to do their specialty better when you're engaging in that. I think those are awesome ideas. In effect, that you could have your own little continuous improvement CE kind of courses going on with your specialists.
Tom, how many times there have been several times I've referred a patient to the oral surgeon or the endodontist, and I said, when they're there, do you mind if I come over and watch what you're doing?
Yeah.
Because I'm going to learn. So if the patient in my office says, what's he going to do? I can now explain to them. So the compliment I get from my specialist is, we never have to sell the patient the case, because you've done it for us. You set the patient up and told them exactly what's going to happen.
Thank you for listening today. We hope you enjoyed this episode. SS White Dental is a leading dental device manufacturer that strives to bring high-quality dental products to market, enabling dentists to work more efficiently and to maximize patient comfort and quality.